Thanks for coming. Lori told me that because the weather's bad, some people might come out tonight because everything's canceled. So, at any rate, my name's Justin Fleming. I'm new to the area. I was born in New Jersey, but I've been in practice for 15 years in Philadelphia. So, I'm excited to be here at UOA, bringing dedicated foot and ankle. The topics that we're going to talk about today, I think, are injuries that all of you are familiar with. Certainly, if you follow the NBA, the NFL, these are injuries that, commonly plague, our favorite athletes. So, I'm hoping that this can be a little bit of a conversation more than a talk, and, please feel free to ask questions, and let's just make it good for anyone. So, anything that's important to you is important to me tonight. So if there's questions, concerns, comments, controversies, let's air them out. Let's talk this for you guys. So at any rate, we'll start with Jones fractures. This is kind of like a favorite thing of mine, just because it's relatively straightforward surgery, which surgeons tend to like things that are relatively uncomplicated. But when we talk about Jones fractures and the things that are controversial, really, number one is the union rates. Like, why do these things take so long to heal? And if we treat them differently, does it make the union rates change? And then the healing times. This is a big deal. So it's a big deal in return to play. It's a big deal if you and I get it, or if you're a 40-year-old plumber and your household relies on your money to keep your mortgage going. So that's a big thing, not only in the athletic realm, but also just in general. And then, what about casting? If we cast them, should we weight bear them? Should we be non-weight bearing? And how long? And then the surgical stabilization. What are the true indications to fix these? What kind of hardware should we use? So, at the end, it'll come down on whether or not we should be placing intramedullary screws. So I would say, in my practice for 15 years in Philadelphia, I was receiving referrals, from surrounding states and local guys. And the one thing that I think that we don't do well, just kind of collectively as a profession, is really identify the nomenclature and truly what the classification system is for these. So the zone 1 injury, this is the injury that, we see in urgent cares, ERs, walk-ins, etc. This is the most common thing that we see all the time. And a zone 1 injury is an avulsion injury of the peroneus brevis and the lateral subplantar fascia. And the difference between this and a Jones fracture is this is a really vascular area, so this thing likes to heal. These are almost never operative. Unless, if they're in the same zip code, they will heal. And yes, it is an intra-articular injury, so the risk of arthritis potentially goes up, but it doesn't seem to clinically correlate. I mean, I've never in my practice seen someone who had post-traumatic arthritis of the lateral metatarsal joint because of that fracture. So this is a completely different animal, and a lot of times I'll see patients that are referred in for a Jones fracture, and thankfully for them, it's just a type 1. Zone 2 is the true Jones fracture. This is the metaphyseal diaphyseal injury. This is actually also intra-articular, and it's intra-articular at the level of the intermetatarsal joint. And so it kind of breaks in between the tertius and the brevis tendons, and it's just distal to the zone 1. And we don't exactly know why it breaks, but we think the termination of the capsular elements and some ligamentous elements potentially create a fulcrum, and the end of the metatarsal is a lever arm. So as someone's planting or rotating, perhaps that's the breakage point. And then zone 3, these are typically diaphyseal stress fractures. We tend to see these in more of a cavus foot. They often have prodromal symptoms, guys complaining of achiness, and then sometimes there's this antecedent injury, and then they have a problem. But basically, zone 2 and zone 3 are lumped in terms of treatment. They're both treated the same, and they both have the same kind of overall course. So the real crux of the problem is blood supply. And so if you look at the vascular anatomy of the bone, so the bone gets blood supply from 3 spots. Number 1 are the myotendinous insertions. Number 2 is the periosteal lining outside the bone. And number 3 is the nutrient artery. And so the nutrient artery in the fifth metatarsal enters the fifth metatarsal on the medial side, and it's got this long antegrade branch and this short retrograde branch. And so the Jones fracture essentially interrupts the retrograde branch, and you get this zone of avascularity. And that is the reason that these things just take a really, really long time to heal. So historically, if we look at what the literature says and what's been done, if you treat these non-operatively, the failure rates are markedly higher. And so there's also a study by Torg. He was an orthopedic surgeon at University of Pennsylvania that has a Torg classification, if you've read on that before. But basically, if you weight bear these patients, the non-union rate is higher as well. This was a non-op treatment, 44% treatment failures. This one had 100% union rate at 21 and a half weeks. I mean, that's significant. It's significant for your athlete, right? It's also significant for the, for a laborer or anybody else. I mean, it'd be significant for you and I. And then this study by Kavanaugh, 67% had delayed union, 11% or 11 of these had refractures. And my guess is that the refractures were just never healed in the first place. So I would probably lump that back into the delayed union number. So it wasn't until clicking until the early 2000s that we started treating these operatively. And they were doing it in athletes and non-athletes. So 22 patients all had intramedullary screws with early weight bearing, 100% union rate with an average time in union of 6.2 weeks. So typically in foot and ankle, if you have a broken bone, 6 weeks is generally how long it takes to heal back before, outside of like talar neck fractures, calcaneal fractures, things that would be outside the athletic arena. But typically this is how long it takes to get bony union. So clinical union was 7.6 weeks. So clinical union is when there's resolution of pain and swelling over the fracture, as you know, and then radiographic time of union 7.5 weeks earlier than casting. So we're taking a big problem, something that doesn't like to heal, and we're able to compress that time significantly. And so obviously this kind of started, this was really a new treatment at the time, and it got people thinking like, well, maybe we should treat these operatively, because typically we treat fractures operatively because they're out of place, right? And they potentially won't heal, or you have an angular deformity, or it's in a joint and there's a potential for arthritis. But Jones fractures rarely displace. So we're fixing fractures for kind of a completely different philosophy. So it's not an articular fracture really, because I'm not going to count the intermetatarsal joint. And they rarely displace. So why are we fixing them? We're fixing them because the time to union and the overall percentage of union is markedly higher. So when I was in school, these are kind of the indications for surgery. Competitive athletes, and if you look at the orthopedic subset, I mean, how many orthopedic surgeons treat competitive athletes? I don't know. At what level? At the high school level, the collegiate level, at the elite athlete level? Probably not that many. I joke, when I was in Philadelphia, I took all the call for a trauma center and some sister house. So I would say that I was treating the urban athletes. Those were basically the bad guys running away from the police officers. So it was a different type of athlete. But at any rate, I think that this is probably small for most practices. Displaced fractures, and we said that Jones fractures rarely displace. Bilateral injuries. So, patients that have polytraumas, obviously you can fix them to get them walking sooner. Torg 2 and 3, that's another classification, but basically it's a radiographic classification on union. So when you start to see these things go on to non-union, right, when the hallmark of non-union on an X-ray for a long bone is when you start to see the intramedullary canal close off. So when you start to get sclerosis. So partial sclerosis is a 2, and then when it's completely non-united, that's a 3. So that would be an indication. But I think now the indication is really for the regular population. I mean, it's certainly for the athletic population. Everyone who has a Jones fracture gets a screw. But I think it's for the regular people like you and I, or at least me, that that would benefit this from the reasons that we've already discussed. So let's talk about the surgical options. Intramedullary screw, obviously open plating, and we'll talk about reasons why 2, 3, 4, and 5 are just not great options. But intramedullary screw is definitely the gold standard for a primary uncomplicated Jones fracture injury. And the reason intramedullary screw fixation is probably the best way to fix these. Number one is the anatomy of the fifth metatarsal just kind of lends itself to placement. So, the fifth metatarsal kind of sits out a little bit, and you can get a straight shot down the canal. So you can't do that obviously for the other metatarsals, but the fifth metatarsal is unique in that way. The second reason is all about blood supply. So this is a study from 1968, but it's still relevant today. And so we talked about the 3 different blood supplies to bone. And the only thing left after you break your bone is the soft tissues only, which is the myotendinous, but really it's the periosteal layer. So when we talk about fracture surgery, we talk about trying to leave a small footprint. So we don't want to take the periosteum off the bone. We don't want to take big surgical approaches because we need that blood supply to get the bone ultimately healed. And if you think about this technique, it really is minimally invasive. It's a small incision, I'll show you, and then we insert the screw. And if I bring it back, if people that have mid-shaft tibial fractures, which is arguably the most difficult fracture to heal, what's the standard of care for that? It's an intramedullary nail. And the reason is, number one, it protects the blood supply around the tibia, and then number two, it's minimally invasive. So it's kind of the same concept, just in a smaller bone. So these are some of the things that we look at, that I would look at in a patient to make sure that I'm getting things right. This is kind of my preoperative checklist. I want to try to get the biggest screw possible. The midfoot is subjected to basically bending forces. And so, the physics behind it are essentially the greater the cross-sectional width of metal, the stronger the resistance is. And so a small increase in the size of the rod, size of the screw, size of the bolt, increases the resistance to bending significantly. It's actually R to the 4th. I'm terrible at math, but that's like a big number. Number two is screw length, because it's important, because sometimes, so this is a torque too. You can see the intramedullary canal, see how it's open here and then it kind of closes down. So that's a sign that this thing probably is not going to heal. So I'm going to look at the distance from here to here, at the most narrow portion of the fifth metatarsal. That's called the isthmus. That determines how big the screw is that I can get in. And then this is the curvature of the metatarsal. So obviously I can't put a straight screw in the curved bone. So I know my screw's got to stop somewhere where the curve starts. Thread length is important. So just kind of basic nuts and bolts types of things. If you can double the number of threads in the screw, you can double the pull-out strength. So pull-out strength is important. There's tendons that attach to the back of the fifth metatarsal that are pulling in this direction. So I want the pull-out strength to be significant. So just imagine if you were hanging like something heavy on your wall, you would want the molly bolt to have a high pull-out strength so that the picture didn't fall off. It's kind of the same type of concept. This is just, so this is the system that I use, the company I use called Arthrex. If you are in the sports world, you've probably either been on the website or heard someone speak. It's definitely a sports-oriented company. But anyway, these are the different sizes that we use, and this is probably outside the scope of the talk, but we generally use solid core screws. So screws come in 2 flavors. They've either got a hole in them or they're completely solid. And the cannulated screws, the ones that have a hole in them, the concept is that you drive a wire into the bone, and if you like the way that the wire is on the x-ray, then you just drop a screw over the wire. And so that's great and convenient, but the downside, again, is that when you take away metal from a rod, you decrease the bending resistance. So we want a solid, more metal is better. Titanium screws versus stainless. So the real kind of argument here is that stainless has its resistance to bending initially is much higher than titanium, but it fatigue fractures quicker. So initial strength is high, but if you cyclically load it, it tends to fracture quicker. Titanium, the initial bending force is not as high, but it tends to undergo cyclical loading better without breakage, and that's why it's important in the midfoot, because we talked about basically the arch of the foot is kind of always has this this kind of cantilever bend to it. Low profile ahead. This is important. I'll illustrate that for you in a minute. So, what is the role of the screw? Because we spend, as physicians, we argue these topics all the time, and basically this is what the literature shows. So the average canal size of the fifth metatarsal, if you look on a CAT scan, is about 5 millimeters. Okay, so if you have a big linebacker, he may still have a small canal. And you may have a small person, and they have a big canal. So you always have to look, but basically a 5 millimeter screw. So when we're under 5, when we're 4, 4.5, the breakage goes up higher. So the failure rates in the literature show that a smaller screw doesn't do as well. So again, kind of, at least in this, bigger is better. What else do I want to tell you about this? This looked at comparisons of cannulated screws versus non-cannulated screws. And here they said that in these two screws, it probably didn't make a difference what we use. So maybe it's more of a theoretical thing versus a clinical thing. All right. So these are kind of intraoperative things that we look at, but again, the fifth metatarsal kind of has it juts out on the lateral side of the foot, kind of lends itself to introducing a screw in. So anytime that we're doing something in surgery that's less invasive, we need to do two things. One is I really need to know all my landmarks. And so one of the things that's really important is the sural nerve. And the sural nerve is just a sensory nerve, and it comes out of the back of the leg and then it splits right where you're going to put your screw. And if you dig that nerve, no one really likes it. Sometimes you get some numbness, sometimes you get some shooting pain there. So that's one thing. And the second thing is you have to bring in, X-ray. We have the X-ray monitor here because I need to really know, because I'm not making a big incision, I need to have a better kind of GPS for overall for the surgery. So this basically just shows the long axis of the fifth metatarsal. So when I'm operating like this, kind of in an AP plane. The X-ray imager is behind me, and then as I'm putting the screw in, I can use that mark to either lift my hand or lower my hand so I get straight down the canal. So this just increases my accuracy. And if we take away all the soft tissues minus the tendon and the bone, this is where the screw is going to go. Some people will say it needs to go above the brevis tendon, right? So just the quick anatomy is the brevis, right? That's a primary everter that pulls the foot out, and that's countered by the posterior tib that pulls the foot in. And then there's the peroneus longus here. And so in non-weight bearing, the peroneus longus is the everter. And in stance, it's actually an inverter because its attachment goes all the way under the foot through the arch to the first metatarsal. So it pulls the first metatarsal down, which tends to be a supinator. And then the last thing is the lateral band of the plantar fascia. So the plantar fascia is basically this, huge wide ligament, but this is called the calcaneometatarsal ligament, and that also provides stability to the lateral side. So essentially, the screw is going to go in this area. The chance of tendon damage is incredibly low despite the high density of tendons in this area, just through the surgical technique. So let's see if I can run this. These procedures generally take about 12 minutes. Patients do go to sleep for it. They get about 3 stitches. And the incision is made behind, right? So this is my fracture line. This is the fifth metatarsal base. And then I know the nerves come this way, so I just need to dilate and make a small enough hole that I can accurately get my guide pin in, the drill bit, all those carpentry things. So there's a sleeve in. You can see the sleeve's pointed upward now, so I know because I've drawn this out before, I'm going to need to lift my hand to get down the long axis of the fifth metatarsal. And again, everything's done under fluoroscopic guidance. You can see the fracture there, and just kind of starting with the drill bit, getting down into the center of the bone. The length of the screw is not terribly important. If you put the screw in too long, you can actually distract the fracture. So sometimes shorter is a little bit better. And there's kind of not a lot to it. We tap the bone to create some threads for the screw to go in, and that's about it. So basically, we wash it out. Patient gets 3 sutures, and they're walking in 10 to 14 days, sometimes sooner if we trust them. So the non-union of these fractures, and I'll just bring up Kevin Durant. Kevin Durant lost a season of the NBA, right? So we had 3 surgeries. Screw goes in, screw comes out, screw goes back in again. It's a big deal. So what can we do on the front side for elite athletes, for high school athletes, for college athletes, just to minimize the chance that this is not going to heal and to minimize the chance of refracture? Well, there's a couple things. One, we already talked about maximizing the screw diameter. So that's going to reduce breakage. Number 2, we want to minimize screw length, because if we put in a screw too long, sometimes it'll take and push that whole segment down and gap the fracture. So we don't need a screw in excessive length. It's usually 40 to 50 millimeters tops. Patients who have a high BMI or have a 5th metatarsal deviation, so meaning that the 5th metatarsal deviates inward like a metaductus foot, or patients that have a high 4th IM angle, right? So the intermetatarsal angle between 4 and 5 is opened up. So if the 5th metatarsal is deviated inward, or if it's deviated really far outward, either of those situations set up the patient to have a less favorable outcome. So it's important for us to recognize that. Number 4 is to consider a CT before return to play. So this bone is like a PVC pipe, right? And when we put the screw in it, sometimes you won't get circumferential cortical healing, and that will leave a small defect in the PVC. And when you have a big guy, or you have someone who's doing explosive movements, that creates a nidus to kind of refracture. And so my guess is for KD, he basically didn't have full healing. So, if I get this, you're not going to CAT scan me, but if you have a 300-pound linebacker, definitely I would want a CAT scan before we kind of let them, turn them loose. And then there's the role of bone marrow concentrate. So, you'll hear stem cells talked about all the time, right? And PRP, those are completely separate things. But sometimes what we do is we will do a bone marrow harvest. So we literally take a trocar, we push in the bone, and I'll show you. But we basically draw out the bone marrow. And what's in the bone marrow are stem cells. And stem cells are a cell that basically can form into any lineage. It can do bone, cartilage, ligament, nerve, any of those things. So at any rate, sometimes we'll use bone marrow concentrate to enhance the biologic activity, right? Because we have an area that's avascular, so we want to create angiogenesis. We want to create new blood vessel growth. And so one way we can do it is with bone marrow, because stem cells can turn into arteries. So that's important. And then biologics like demineralized bone matrix that tends to turn on the osteoblasts that make bone. PRP, there's certainly some role for that. And then the last thing is when we put our screws in, we want to make sure that the head of the screw is not hanging out. So we know that if we take the screw out, the refracture rate is high. So my job as a surgeon is to pick a screw that's kind of have a short head profile, but also to make sure that it's not sitting in the joint, because over time, so if you look at all the tarsometatarsal joints, 4 and 5 have the most motion by 4 times all the other joints. So this is the most mobile segment in the lateral column of the foot. And if the head of the screw there is going to be irritating to the player, it's got to come out, chance of refracture becomes higher. So we need to make sure that on the front end at the surgery that we take 30 seconds, look at it on x-ray, and make sure that that's not the issue. These are just kind of a laundry list of literature that's available looking at bone marrow concentrate in studies, and it's probably not super important to all of us, but this will be important to you. So we have a couple of really good studies on NFL and NBA elite athletes. Yeah, I'm sure you're all familiar with Bob Anderson, but if you're not, Bob Anderson was in North Carolina. I think he's now in Minnesota or Wisconsin. But anyway, he was essentially the NFL guru. You know, if you had an Achilles rupture, you had a turf toe injury, you had a Liz Frank injury, Bob Anderson probably did your surgery. So at any rate, they looked at 21 elite athletes with non-unions or refractures, and essentially all of them got an intramedullary screw, either 5.5 millimeters or greater, so they optimized screw size. And this is autogenous bone graft, so they took it from the patient, either from calcaneus, tibia, iliac crest, or bone marrow concentrate. And so return to play was 12 and a half weeks for these elite athletes with a Jones fracture. And 100% of these healed and 1 refracture. So this is a pretty good recipe to get people healed. I mean, any surgery that you can do that heals 100% of the time, like, sign me up for that, because that's what I'd like to do all day. This is from Martin O'Malley and some people at HSS. 10 NBA players, 7 of them got IM screws with bone marrow concentrate. 3 had IM screws with open autologous bone grafting. So basically, they put the screw in, they made an incision, they opened up the non-union site, and then he took the patient's bone and actually packed it in. Versus the bone marrow concentrate, they stuck the screw in and they took the needle with the bone marrow concentrate and squirted it on the fracture. So radiographic healing was 7.5 weeks. Return to play was 10 weeks. Interestingly enough, we tend to correlate Jones fractures. I tend to correlate Jones fractures with patients that have high arch feet, right? Because you put more load on the lateral column of the foot. That's not what they found in this study. They actually found that 70% of the patients actually had flat foot, which is contrary to most of the things we know. The second thing that was unique to this patient population is that they had a prominent fifth metatarsal base. So, you know, you'll see this certainly in bigger guys, bigger players, but the fifth metatarsal is kind of just hanging out. And sometimes there's some bursal projection beneath it, but at any rate, these were the risk factors they identified in elite athletes for refracture. High fifth metatarsal deviation we talked about, either really far in, really far out. A lot of body weight, or you know, a high BMI. So this is the technique for bone marrow concentrate. It's minimally invasive. Obviously, the patient's asleep, so before the tourniquet goes up, we take a trocar and you just tap it into the bone. The calcaneus is really soft. It's like an egg, right? The outside is a thin shell, inside soft. And then you work this syringe and you basically extract the bone marrow. And then that looks like this. And then when you get enough, you put it in this machine, and then you can literally dial out. The technology is so unbelievable now. Like, with their iPhone in the room, they can, if I say, like, I want to get more platelets or more white blood cells or whatever I believe is the magical recipe, they can tell this machine, and that's how it will separate out. It's pretty cool. And then under fluoroscopy, we can make a small incision and we can just get the bone marrow concentrate exactly on the fracture. So this is some of the techniques that we use for someone who maybe had a refracture or was at higher risk on a primary Jones fracture. When do we do open bone grafting? Basically, if we have a non-union. If we talked about the TOR 3, it's rare that patients get large defects unless they've had an open plating and they get an area of dead bone that has to be removed, which is just very, very common. But sometimes what you would do is we would place the screw into the fifth metatarsal and then pull it out and make a small incision when the bone did not heal. And then we use osteotomes, curettes, kind of all these different tools to kind of freshen up the bone site. So when bone doesn't heal, it lays down scar tissue. And scar tissue basically gets interposed between the two good bone ends. So we got to get all the scar tissue out, so then we can put bone graft in, and then when we reinsert the screw to get some compression. And one of the things that we do is we make an approach kind of towards the bottom of the foot, and that stays away from the important arteries that supply the bone. So this was actually a charge nurse of in the hospital I worked at in Philadelphia. So this is not an acute injury, right? So she is definitely, so this would be zone 1 here, and this would be zone 2 here. So she basically has a diaphyseal stress fracture. You can see the metatarsus foot, right? All the metatarsals are inward. She's going to overload the lateral column, and whatever happened, she got this stress fracture, and then didn't really bother her, and then now, so essentially the intramedullary canal is completely closed off on both sides. So this is definitely a non-union. Her primary care doctor sent her for an MRI for some reason, but anyway, I showed it to you just so that you could see what a non-union looks like on an MRI. But a couple things when the bone is crooked like this, so this is not a straight path, right? So essentially when this breaks and doesn't heal, it just follows all the other metatarsals, right? Because there's ligaments attached, right? The deep transverse intermetatarsal ligament. And so essentially this will just follow everything else. So now you have a bone that's not healed, and you have some angular deformity as well, which isn't like terribly difficult to deal with. So I've made a small incision. This is just a retractor holding open the skin around the bone. So I've got out all the scar tissue, and then I've essentially pulled the 5th metatarsal over so I get a straight shot with the drill. And then we go in with the guide pin, and then we place a screw. So not terribly complex. Again, these are relatively simple procedures. And here she is. And again, I would not CAT scan this patient, but you have 2 cortices at least on this X-ray, and I can see the plantar cortex. So the plantar lateral cortex is always the last thing to heal on joint fractures. I don't have a good scientific reason why, but it's always plantar lateral that's the last thing to heal. And so this oblique X-ray gives us a really nice view of the plantar lateral cortex. So that would be important. That would be something I would want to see on someone before I let them return to play. And if I wasn't 100% confident, that person would absolutely positively get a CAT scan, just because the risk of having something bad here, it would be a difficult revision and more time. So at any rate, the patients, they stay in a splint. I let them weight bear when the wound is sealed. So sealed just means it's not draining anymore, which can be a couple days, it can be a week, depends on patient. Then they go into a cam walker. If you're an athlete, you can ride a bike in 10 days without resistance. You can swim plus or minus on a rower. If you're lucky enough to have like a 0G treadmill, you could obviously do that. And then they're just in a cam walker. And they're generally healed radiographically in 6 weeks, and they can come out into a sneaker with a stiff sole. Sometimes orthotics can be helpful depending on the foot type. Like I showed you that basketball player that kind of had that prominence around the 5th metatarsal. So that person definitely would benefit from functional orthotic, just to try to take some weight off the operative. And then I think the hardest thing for competitive athletes is just figuring out, like, they're clinically healed, are they radiographically healed, and then what's their return to play at that point. So there are a few complications. This is, these are the bad things that can happen, with this kind of bending. So that's why we want to get a solid core screw that's big. Refracture is either we got them back too early, the bone didn't heal, or I dropped the ball in some fashion. And then, lastly is the sural nerve. This is how it comes down. It bifurcates right around the 5th metatarsal, so we have to be really careful of that. Again, it's a sensory nerve, so if they lose some feeling, it's not the end of the world, but obviously it's not optimal. So in summary, basically this is minimally invasive surgery. It preserves the soft tissues, which are important because we have an avascular bone, so we want to preserve anything that potentially can get it nutrients and blood supply. And by placing a screw, now we have predictable union rates. The union rates are quicker, and then we can get patients back weight bearing and get them back on the field or the court sooner. So I think that might be it. Yeah. Any questions? Any experience with Jones fractures? Is that something that I'll see a lot, or is that pretty uncommon? That's good if you're not seeing them. That means your players are healthy. Yeah. So any questions on this topic? Yes, sir.
I had about a 280-pound football player who broke his foot doing shot put, just slammed right into the toe board and went to track, and did not have surgery, and seems to be doing okay so far. Anything to worry about with him?
You know, I don't. I mean, I think the best thing to do is look at an X-ray. So if we looked at an X-ray and he was completely healed, then my concern would be low. But I certainly would plan in his mind if, you know, if you're getting some pain over there, your foot's aching, you know, because obviously that would be kind of the rise of a stress fracture or something in that. So I think that's pretty much all I would tell them. So if it happened in the winter and you're now maybe 2 months out, 3 months out, yeah. And what's he doing now?
He's doing shot put, discus, javelin.
Yeah. Okay. So I think those things are, you know, they're not high impact, right? But they're probably medium impact, low to medium impact. So I think that would be a reasonable course of recovery for them. Yeah.
How long have you been utilizing the screws for the surgery? Like a decade or two, or more? I'm just curious.
How old do I look, Trish?
You said you were 15 years.
Yeah, exactly. All right, you're a good listener. So when I was first in practice, I treated everyone non-operatively. And patients would be in casts, they would be on blood thinners, they'd be on crutches, and sometimes they weren't healed at 3 months. So I would say to them when they were healed, like, if I offered you a screw back then, and I told you could walk in 2 weeks, like, would you have? They're like, yeah, bozo, we would have taken that, of course, you know. So at any rate, there's the clinical side, but I would say probably probably pretty quickly, 2 years maybe after I started practicing, I became more aggressive with them, and I've not had a single non-union and Jones fracture yet. So.
But we haven't enough data to see how these people do long-term over time, like a couple decades. Is there any concern that you would have that as the person ages that there would be problems with that? It just seems so odd to me that you're going to keep a screw in such an important area where there's so much weight there.
Yeah, so I think your point is well taken, but I will tell you that in my career we're doing 600 to 700 surgeries a year, and the majority of the implants that we put in 60 to 70% of that's fracture care. Majority of the implants stay. So things that are not tolerated well, tend to be probably syndesmotic screws. And if you have a Liz Frank injury and you put plates and screws like someone under the age of 50, they tend to not like that at all. Outside of that, it's pretty,
Well, it's not a whole lot when you think about it, hardware, but
Yeah.
just something I was thinking.
Yeah.
It's amazing the difference in the healing, though. That's pretty dramatic.
Yeah, I mean, the healing time gets cut in half, and then the rate goes up probably 60, 70%. So, and honestly, for most patients, it's not a hard sell. I mean, it's probably an easier day than going to the dentist. They get an IV in their arm, they're asleep. 12 minutes later, they're outside. And so I can make it home by lunch. So it's pretty good.
What's the insurance reimbursement rate?
I have no. I'm just
a
a dumb guy that puts a screw in. I have no idea.
I was just curious.
Yeah.
They're okay, they're not.
Yeah, so I would say probably, I'm just guessing in Philadelphia it was pretty bad, but my guess is the screw would probably eat up the surgeon, whatever the surgeon got. So, when I was doing a tri-mal ankle fracture, they were paying like $900, something like that, $1,000, $1,500 in hardware. So I don't know for this procedure, because it's a percutaneous procedure, so it's going to bill out less. But I'm not smart enough to know. So if I look, so the honest answer is, if I actually look at what I get paid to do, I'll probably not be happy. So it's just easier for me to treat patients. Like when I pull a chart off the wall, I don't even look at the patient's insurance, because honestly, at the end of the day, like it's not going to affect what I do. And but I don't know. I'm sure it's different in that the reimbursement in New Jersey is going to be markedly higher than it was in Philadelphia. But the answer is I don't know. Yeah. Yes, sir.
Some of those screws look like they only have threads at the very distal, end of it, and there was one that you showed where the bent had more threads.
Yeah, so there's 3 different screw types that I showed, and so this screw is called an Acute screw. It's basically, so this is a compression screw. So typically to get compression, you get threads on this end, nothing in the middle, and then the head. So as you advance it, the head pushes and you compress. So this screw has, it's called a variable pitch screw. So the pitch on the threads is different on each end. So as you're tightening them, it's moving the segments independently toward each other. So that was like it's also called a Herbert screw. It's used in scaphoid fractures, navicular fractures, things like that. That's a cannulated screw. And then this screw was before companies had Jones fracture screws. So I actually took this and I took a Cebitone, which is like a, monster garage thing. I just cut the screw down and fit it when I needed. So that's, Trish, that's old school right there. Cutting your screws in the norm, so. Okay. Anything else? Good. All right. Lori told me I had to keep you for exactly 2 hours. I told her that's not fair, but I'm joking. Okay. All right. So the next thing we'll cover is Achilles tendon ruptures. And again, just to give you some sense, if you remember the days of Dan Marino, Dominique Wilkins, some pretty high-level athletes, right? I mean, their careers were essentially ended by Achilles tendon ruptures. And, now you have like Richard Sherman who will come back, Kobe Bryant. There's been a lot of guys that are now able to recover from Achilles tendon ruptures. So, at any rate, just these are the things that we'll cover tonight. I put this in because it freaks me out a little bit, to be honest, and I just thought it was like, if you thought you were tough, you're just not, because this guy is a Dutch anatomist, and he dissected his own amputated leg. So, yeah, good stuff, right? The Quada classification, so most of the classifications in foot and ankle are descriptive, but they're not prognostic, meaning, okay, I can say that you have a Quada 2, but it doesn't tell me how you're going to do it. So it's kind of a useless classification for the most part, unless we're down here, because then we have a big defect in the tendon, and I have to figure out how are we going to lengthen the tendon, bring it down, do I need to transfer a tendon, do I need to graft it, whatever. But basically, this is probably the most common classification for Achilles tendon ruptures, but we never use it, but now you know. So this is, Achilles tendon ruptures are a bimodal distribution, meaning it happens in 2 different parts of our lives. The first peak is in the 4th and 5th decade, and I just turned 44, so I'm like I'm in there. But this is kind of the weekend warriors that we typically think about. And then there's a smaller peak that occurs in the 8th decade. And so, interestingly enough, the left Achilles tendon appears to be injured more than the right, and maybe there's also a blood group type O that tends to be more common. So, again, the commonality between the Jones fracture and this is basically an issue of blood supply. So we're talking about things that have that don't heal well tonight, right? So if you get an injury to your Achilles tendon, the blood supply is not great, so it has a hard time healing itself, right? And so at any rate, if you look at the blood supply, there's kind of this big area in the center where there's really a lack of blood vessels, and this is known as the watershed area, and it's basically 4 to 6 centimeters above the insertion of the Achilles, and this is typically where people rupture their Achilles most commonly. And so we don't exactly know why, but certainly there's a mechanical theory. I will see probably 2 or 3 patients a year that get cortisone injections around the Achilles. So that's awful that the Achilles tendon will rupture. So there's a couple places in foot and ankle we don't inject. One is the Achilles tendon, for sure. Number 2 is the posterior tibial tendon. And number 3 is the plantar plate. Those big fibrocartilaginous ligaments on the bottom of the foot. If you inject them, they will tear in the same way. Fluoroquinolones like Levaquin, if people are taking them because they have the flu or head cold, pneumonia, whatever, basically this interferes with protein synthesis, and there's a correlation between fluoroquinolone use and tendonitis, tendinopathy, right? So tendonitis is inflammation of the vascular supply of the tendon. Tendinopathy is a non-inflammatory degeneration inside the tendon. And then the third thing is complete tendon rupture. And there's some other things, obviously, but I think most of us agree it's generally like an explosive type of force where there's a significant load on the tendon. And this is the distribution. Again, we talked about the watershed area, but basically 75% here. A very small portion get these, they're called sleeve avulsions. And so basically the Achilles tendon, the internal cables of the tendon kind of pull off the bone. It is a very rare injury. It happens in 2 different ways. Patients that have chronic insertional calcific Achilles tendinopathy, so that's a really big word, but basically where you have degeneration of the Achilles tendon at the insertion, the tendon becomes weak, it becomes inelastic, they explode, the tendon breaks. The second group is really diabetics who have renal disease. They tend to rupture their tendon here. Really uncommonly, you get myotendinous injuries. So basically, where the gastroc aponeurosis inserts into the gastroc or the soleus, it'll tear there as well, and that's almost like a hamstring type of injury. So this was my X-ray tech a couple years ago. Young guy in his 20s is getting out of his car to go play flag football. Didn't even make it. And so this is an interesting injury, but he has a delamination, right? So this is the soleus, this is the gastroc up here, and this is kind of the conjoined tendon. So he basically completely delaminated the gastroc and the soleus. So it's kind of a fun thing. For me, it wasn't so fun for him, obviously, but he had a big zipper on the back of his leg. Typically, people report kind of getting hit in the back of the leg, and they will swear that someone like stuck up behind them and hit them with a bat, or they got hit with a sniper rifle from the grassy knoll. But everyone swears they got hit, and oftentimes there's no one around. And the pain is variable. I have patients that walk in on an Achilles rupture and say, "I don't know, it just kind of hurts back here, doc." And then you have some people that are on crutches, but these tend to hurt a lot less than ankle fractures and some of the other things that we see. And then the Thompson test. So this is like, if you take away only one thing, the Thompson test is the most important. You don't need an MRI to diagnose an Achilles rupture. We just need the Thompson test. And so the way that you do that is you have someone lay down. Are you all familiar with the Thompson test? Is that something that's like relatively common? Okay, so I don't want to belabor the point, but basically this is the same patient. You can see foot down where he's got good plantar flexion, and here we got nothing. And so I don't know where the rupture is, although sometimes I can feel it. So it's either here, here, or here, and then we have to figure out whether it's a surgical problem, non-surgical problem, et cetera. So I would generally get X-rays for all these, because you'll be surprised what you see sometimes. Sometimes you'll get some large avulsive injuries from the back of the calcaneus that make it easier because you don't have a soft tissue problem. You can just fix the bone. Ultrasound, I think, plays a role if you can't get an MRI. If someone has like maybe a pacemaker in, ultrasound would be a reasonable option. It's certainly much less expensive than an MRI. But people usually use MRI if they're going to be treated conservatively and they're looking at the tendon ends to make sure they're together, right? So if you have someone with acute rupture and you put them in neutral, you're going to gap the tendon, and then when they heal, the myotendinous length is not going to be what it was before. They're going to lose push-off power. So that would be, one thing that you could consider. And then obviously, an MRI is probably a gold standard. And so I don't do this to figure out whether the tendon's ruptured or not. I do this for surgical planning to figure out where the zone of the tendon is that's injured, and then what's the best way to help the patient. And there's just an ultrasound just showing that there's no tendon between the arrows. So I would say probably 6 or 7 years ago, I changed my surgical approach to Achilles tendon ruptures, and it's been a huge, I would say, game changer for me. But I'll show you the technique that I'm using. But we've gone from kind of an open approach, a big open approach, to a small incision about that big. We've cut the OR time down to about 30 minutes. And I'll show it to you. It's pretty exciting for me. And the best thing always is to have a big patient benefit and a big surgeon benefit. So that's a win-win. And the majority of guys now in the NBA and NFL that are getting their Achilles tendon repairs are going to use the technique that I'm going to show you tonight. So the goals of treatment, obviously, to prevent complications. So historically, people have shied away from Achilles tendon repairs because of several things. One, and the biggest thing, is wound dehiscence. So I showed you the blood supply to the tendon, but the blood supply to the skin in the back of the leg is about the same. It's just not very good. It's just the whole area is relatively avascular. So preventing complications, and then optimizing rapid return to full function, and really reestablishing push-off power. So if you're 65 years old, 70 years old, in your household or community ambulator, probably not huge, if your Achilles tendon is a little bit long, but for everyone in this room, it's a big deal. And if you have weakness in your Achilles, it definitely can give you some disability for sure. So I think the number one question that we have to ask is, should we be fixing them? And so this has kind of been highlighted in the last couple of years as potentially some controversial things. But this was a study in JBJS British. This was 2001, and the rate of re-rupture after non-surgical treatment was 1 in 5. And then it was less than 2% if we fixed it surgically. So now that's a huge benefit, right? So now we have to weigh it against what the risks are. But most people that advocate fixing Achilles tendon ruptures will quote this study, and obviously the risk benefit of fixing seems to be much, much higher in this situation. So then in 2010, JBJS, this study came out of Canada, and they were using an accelerated functional rehab program. So basically, patient was seen with a rupture. They were seen within 48 hours by the physician, the athletic trainer, and the physical therapist who brought them through this very intense course, and they'd never had surgery. And so they took these results, and they took the results that were previously published, and they said, see, you don't need to fix Achilles tendon ruptures because we're doing the same. So if you have that situation where you can put that protocol in place, and you have patients that show up on time, and you have all the staff to do it, I think it's fine. The majority of the time, it just doesn't happen. And oftentimes, I see patients like this that come in 2 weeks out. So if you come to me with an Achilles rupture and you're 2 weeks out, you cannot have non-operative treatment because those two tendon ends are not going to go back together. So to enact functional rehab, you have to see patients, relatively quickly. So anyway, if you haven't figured out, I'm a believer that we should fix Achilles tendon ruptures. And so if you believe that, then what's the best way to do it? Because there's really two options. There's percutaneous repair, and then there's open repair. And this was out of England. So this group and the technique that they used, they thought that the percutaneous repair was superior to the open repair. And the reason why was not because the percutaneous repair was stronger or whatever, because they kind of did the same, but basically statistically significant reduction in infection rates and surgery. So the big risk forever for fixing Achilles tendon ruptures was if you get an infection. If you get an infection, it's an awful day for everyone. But if you do it percutaneous, the chance of getting an infection is less. So we're essentially, by doing it percutaneous, we're minimizing the risk to the patient, and we're still giving them, we're still restoring their myotendinous length, which is important for overall function. So these are the benefits of percutaneous repair. Obviously, it's minimally invasive, so we have less wound complications. Again, soft tissue preservation, right? Because we keep talking, the Achilles tendon is not a very vascular area, so we want to preserve everything that can get the tendon to heal. Cosmetic, most guys get it, don't care. But anyway, obviously, we can make it look nice. And then we look at the strength, and there's some the technique that I'm going to show you has some of these different options. One of the things that when I was repairing them open was that there's something called knot stack irritation. So for a lot of these sutures, they're non-absorbable. So sutures, when we sew tendon or ligament, they come in two flavors. They either go away by themselves, they hydrolyze in the body back to CO2 and water, or they stick around forever. So the way that we figure out whether we use an absorbable or non-absorbable is we have to figure out the tendon or ligament that we're repairing, how long is it going to take to heal? And so if it's going to take a long time to heal, and then we need to use something that's non-absorbable, it's going to stay in the body forever, just like a screw or plate, etc. Because if we use a non-absorbable, and the non-absorbable loses 50% strength by 6 weeks, but the tendon takes 8 weeks to heal, the chance of us losing the knot is a big deal. So anyway, I digress, but the sutures that are non-absorbable, they're you have to tie lots of knots to get it to stay. So that creates what's called a knot stack. And in foot and ankle, it's a big deal because there's not a lot of soft tissue around the foot and ankle. So when the swelling all goes down from the Achilles rupture, you can feel these knot stacks. Sometimes they pop through the skin, then you got to go back into surgery and take them out. So anyway, this technique eliminates all that. There's a technique that's called bridge plating. Okay, and so I want you to put your fracture caps on for a minute. But I talked before about tibial fractures, a really hard fracture to heal. So one concept is what we do is called bridge plating. And bridge plating literally spans an injured segment. It maximizes the soft tissue preservation, which shortens the recovery time and makes the bone heal quicker. Kind of things you've heard already, right? And so this is a patient that has a distal tibial fracture. We put next fix on, we let the swelling go down, and I make a small incision and I slide this huge plate up his tibia, and then we anchor it to the top and to the bottom, and that bypasses or bridges the fracture. And the purpose of that is, again, we're sparing the periosteum around the bone, and that allows this bone to heal. And so there it is there. And so if you look, we got a big plate through small incisions, and that would be our goal. So we maximum stability, small surgical footprint, that's the key. Well, the technique that I'm going to show you is basically the same. I would call it a bridge suture. So we're not fixing bone, we're fixing tendon, but we're doing the same thing. We're spanning the injured segment of the tendon. We're maximizing the soft tissue preservation, and we can shorten the recovery time and more predictable union rates, right? So sometimes tendons don't heal, so that's a tendon non-union. So the outside of the bone is called the periosteum, but the outside of the tendon is called the peritoneum. They do the same things, they're the vascular lining of different structures. So when I used to do Achilles ruptures, this is what I would do. Make a big whack on the back of the leg. This is the rupture site. This is called the peritoneum. That is the vascular layer that supplies the blood to the Achilles tendon. You have to take it off to repair the tendon to put the suture in. It doesn't make a lot of sense, right? We have an area that doesn't like to heal, and now I'm taking all the soft tissue off, and then I'm going to put it back together again. So it doesn't make a lot of sense. But anyway, this is what still a lot of people do, and I'm not saying there's anything wrong with it, but maybe there's a better mousetrap to get it fixed. So okay, so there are two different ways that we can do what's called percutaneous tendon repair. So I'll show you how these jigs work, but there's two companies that make it, and I use the jig on this side, and the reason I use it is that they've done the suture repair here, and they have a pin in the calcaneus and a pin up here, and they try to pull it apart to see which knot is stronger by which company. Spoiler alert, but the one on the right wins because the way that the sutures come through the tendon. Sometimes we can change the way the suture is, right? So a lot of physics tonight, but pressure equals force over area, right? So think about the seatbelt in your car, it's wide, right? So if you get in an accident, when you hit, it disperses the force across your chest. So if you had a thin wire as your seatbelt and you go through, the same amount of force goes through, the wire will cut you in half, right? So if we can make, or we can repair tendons with thicker suture, this is flat, it's not round, then we can disperse the amount of force on the tendon, and then it makes less rip through, right? So one of the problems is you have an Achilles tendon rupture, the guy falls down, and this wire, this cable, kind of pulls through the tendon, and then it kind of opens up again. So one thing that we can do is we can actually change the suture that we use reduce the amount of tear through the tendon. So lots of different kind of like tips and tricks. But anyway, this is the incision that I use. And let me just show you the video. So again, it's about takes about 30 minutes to do this procedure. But basically a small incision. The red stuff here is a peritoneum, so that's the blood supply, right? That's the lining of the tendon. And what you're looking down, right, is the tendon rupture. So that is a portion of the tendon that's ruptured. And they often describe it as having like a mop handle appearance, right? It's kind of just shredded like spaghetti. You can see it right there. And so what we do is we insert this jig right up next to the tendon. And the arms of this will internally expand, and now we have a targeting device around the tendon. So basically, these outriggers here, as I place a wire through the outrigger, it will go through the two central portions, and the tendon's in between. So now I've captured the tendon. So the first one goes in just as an anchor, so it anchors the tendon to the jig. And then we're going to pass a series of these. It would take less than 30 minutes if I just moved it a little quicker. Must have been the residents that day. But they're color-coded sutures, so as we pass each one through, now the suture is actually inside the tendon through the jig. So then there's a way to create a locking stitch so the sutures don't go straight through. Now as we pull these out, now the sutures are all inside and capture the proximal stump of the Achilles tendon. And we've done what we did before through a very big incision through a smaller incision. So now the option is you can flip this jig to go backwards down, and then you have knots. And the other option is, and I'll show you that, but here we're just checking for pull through. So I want to make sure that the suture is secure in the Achilles tendon before the patient gets off the table. Because I don't want to do a range of motion. Everyone falls. I want to make sure if something's going to pull out, it's going to pull out now, but I'm just going to reinsert the jig and start again. So I want to make sure that I have a good anchor on the tendon. And then I'm going to go back down to the bottom of the heel. And so in this technique, there's going to be no knots. We're basically going to anchor the proximal stump to these sutures into here with basically anchors that you can use in the shoulder, the knee. And so now I'm just preparing the back of the calcaneus. So since this technique's evolved, I don't actually put them in the back anymore because I think it creates a little bit too much irritation. So we actually take a more vertical approach, kind of side by side. And those will be off the heel counter in the shoe. And then this is called a banana lasso. So it has a nitinol wire inside of it. So that I'm going to fish it through the distal stump of the Achilles. And I have this like wire loop here. And I'm going to pass all those sutures through the wire loop. And then when I pull them out the bottom, it's like when the nurses first see this, they get really excited. It's like a pretty cool thing. So all of these sutures are color coded. My fellow last year was colorblind. So sometimes I would just leave the room and see how he did, but he didn't think it was that funny actually. But, so now as I dorsiflex the foot, you'll see the tendon ends come together. And this is how it will look. And so we, again, preserve the periosity and small incisions. And then we use these anchors. These are made of PEEK, which is polyethylene something, I forget. But anyway, it is a slowly absorbable anchor. And then we're going to insert these under tension into the calcaneus. The number one reason that Achilles tendon ruptures fail is because the knots slip and break. So if you remove the knots, remove that knot stack irritation, and you remove a mode of failure. So the only way this can fail is if all those sutures pull through the Achilles. And that's just the sound of the screw getting good purchase into the bone. I'll do the same thing on the other side. And then you're just testing the repair. If it gaps, then I might run a box suture around the tendon ends. But I generally leave these patients in full plantar flexion. A lot of surgeons will try to match it to the opposite side. If you do that, they tend to get over lengthened. So they'll be at max plantar flexion for 2 weeks. Then they go up to 45 degrees, and at 4 weeks they're at neutral. And then, if you have someone with a solid tendon repair like this, they can walk an Achilles boot with a 20-degree wedge at week 2 to 3. So you need a 20-degree wedge because if you bend the ankle 20 degrees, it takes the gastroc out. So you get a lot less pull on the Achilles, less chance that something bad's going to happen. So at any rate, this is the end result. Patients get back quicker. There's a higher strength of soft tissue fixation. It's minimally invasive. Lower incidence of latent infection, mostly from the sutures popping through the skin. It reduces postoperative swell like DVT, atrophy, elongation. And this was a study again by Bob Anderson looking at his elite athletes in the NFL. So, again, this is what the guys in the NFL are getting. And this is the angle that we're putting in. It's a little bit higher. This is what I want to show you. So, if this was you, what would you want? You want this one or you want this one? Because they basically have the same strength. Thank you, Trish. Yeah, right. So it's a big hit. And the problem is, if these get infected, you got to go and pull all this stuff out. Which is like if you stuck bubble gum in a hairbrush before, like that's about what it, So it's a big deal. So. Oh yeah. Okay. So where's the research? This was a buddy of mine up in New York. 34 patients with mid-substance ruptures returned to play in 18 weeks. No wound complications, no morbidity, no re-ruptures. So, and then for the average person, this was a Philadelphia firefighter. So in Philadelphia, pretzels and cheesesteaks are a big deal. This is not an elite athlete. This guy's at 9 weeks post-Achilles repair. He's not a small human being. In my old practice, my partner ruptured his Achilles tendon. He was a sprinter from Cornell University. It took him 9 months to stand on his toes again. So, a pretty big deal if we can get these guys back. I think we can do it for athletes. And then sometimes the stuff we've already covered, but sometimes we'll also use PRP in around the areas when it closed. If nothing else, it reduces infection rate. And then we use something called a jump start, but basically it's a silver impregnated dressing over top, which reduces the bacterial load around the incision, and hopefully reduces surgical site infections. So. Okay. Any questions, thoughts? Oh yeah, I know. I know. Yes, sir.
How soon do you start therapy?
So I'll let them do just kind of general range of motion by themselves, at 2 weeks. But by 4 weeks, so between 2 and 4 weeks, they can get in a pool if their wound is good, or they can get on a bike without resistance. Outside of that, it's maybe a little bit more challenging, but definitely, full go at 6 weeks. So 20-degree wedge at 2 weeks. By 1 month out, they are so they drop a 10-degree wedge every 2 weeks. So they're flat by 6 weeks, and then they go into a shoe with a 1/2-inch heel lift for 6 months. Especially if you're in a cleated sport where you get kind of a negative heel position, that's probably where I'm more concerned. So, yes, sir.
Does the location of the rupture change technique at all?
It does. So if you have a distal rupture, it's like you're non-weight bearing 6 weeks in a cast. It's a bigger deal. So that's a much slower. And those patients generally have diseased tendon. So this is like native good tendon is just torn. So that's a bigger deal. And then if they have the ones that are really uncommon are the myotendinous tears. If they have a positive Thompson test, we fix them. We can't fix them like that, but yet make an open incision and then basically sew the tendon and muscle. So I would say that's actually a little bit slower as well, just because you can't anchor the tendon to the bone like we can here. So that's a little bit more difficult. All right. Well, I'm out of words, so I think. That's it, but yeah. So anyway, it's a privilege to have the opportunity to kind of hang out with you guys, and if there's anything that I can do for you, even if you have a quick question or something, I'll give you guys my cell phone number. I'm always here, always available, and happy to help in any way. Great. Thanks for having me tonight. Appreciate it.